Okay, good evening, everyone. Uh, those of you who can possibly put your videos on, I would request you to put your videos on. And in fact, those of you who don't have any background noise, you can keep your uh, mic on also so that you can answer fast. If you think you can't put on your video, at least put your mic on. So, sir, can you hear my voice?
Yes, sir. Yes, sir.
Okay. Okay. So today we are going to discuss approach to chronic diarrhea. For my Hinduja students, this might become a small repetition, but it's good. It will be a revision for them. So I'll request them to answer second. So other students can answer first, and if they don't, then the Hinduja students can answer. So uh, let's keep it interactive and let's start. This will be like a mixture of writing a theory answer as well as if you are dealing with a case, then you can develop your approach to the case as well. I'll just share the screen. Will you see the screen?
Yes, sir.
Okay. Fine. So let's start with terminology. What is your concept of chronic diarrhea? The patient comes to you, mother comes with a child and says that my child has loose motion since that. So what duration will you call it chronic diarrhea?
14 days.
14 days. Okay. Any other answer?
More than or equal to 4 weeks.
Okay. More than or equal to 4 weeks. Okay. So basically, before we decide what is the duration, suppose whether you take it 14 days or you take it 4 weeks. Suppose the child comes to you on 12 days and the child comes to you on 26 days, 2 days short of your duration. What is the difference? What will you tell him? Come after 2 days, then I will treat your chronic diarrhea. Correct? He's coming at 12 days. So you tell him come after 2 days. When it becomes 14 days, I'll treat your chronic diarrhea. So what is the logic of using this terminology? Anyone?
Chronic diarrhea is insidious onset.
Okay. So insidious onset would mean even a 5-day diarrhea which is insidious in onset can be chronic. No? My question is, what is the purpose of separating an acute diarrhea from a chronic diarrhea?
To differentiate from persistent diarrhea,
What is persistent diarrhea?
acute in onset and more more than equal to 14 days duration.
Okay, very good. So there is no consensus on the definition, but generally when it is more than 14 days, you talk of it as chronic. Same is persistent, you talk of it as persistent. So what is the difference? The difference is that if the child has been bang normal, started with one acute episode, which did not get better, then you call it persistent diarrhea. And chronic diarrhea is usually much longer in duration. And obviously, you have to again differentiate between recurrent acute episodes versus a actual chronic diarrhea. So what is the, so my first question, the answer to that is that your thought process is different when you use the word chronic diarrhea. So it is not important that he has come to you on 13th day, then you can't think and you tell him come tomorrow, then I'll make it chronic diarrhea and I'll treat. The whole purpose is that your causes, your thought process is different for chronic versus different for acute. So that is the whole idea, okay, of differentiating into these things. So when you get what seems to be chronic, you have to first decide that it is not acute followed by non-resolution, which makes it persistent, versus recurrent acute episodes with normalcy in between, versus a really chronic diarrhea. So there are these three different categories that you think of, right? Okay. Now, how do you take the history of such a child? So somebody just said insidious onset. So if the cause is that of a chronic diarrhea, for example, say celiac disease, then the onset will be insidious. You're right. Okay. So more than, so one is that acute onset versus the insidious onset. Does the age matter? When did it start? Now we are talking of chronic. That means it's 2 weeks, 3 weeks, 4 weeks, or even longer. So does the age matter?
Yes, sir, age matter.
Hmm.
In infant and toddler, more than 10 gram per kg per day, and in older children, more than 200 gram per day. A stool.
So Priyadarshi, you are right in theory, and it helps you to write these stuff in theory paper. But tell me, will any patient ever measure the stool to tell you the grams? No, right? So
Yeah.
these are all theoretical discussions, which is good to know. What I'm asking is, suppose if infant chronic diarrhea started when the infant was 1 month of age, what is your thought process?
Lactose
Sir,
intolerance.
Sorry,
Any intolerance, lactose intolerance.
okay, lactose intolerance. Anything else?
sir will ask for the breastfeeding, the pattern of breastfeeding, whether fore milk, hind milk, both are given or not. That will increase frequency of the stool. Also, the bottle, if bottle feeding or any top feed has been started. So all those common causes we would like to look for.
Excellent. Okay. So remember that a very small infant will often come with what is not diarrhea at all. So if the baby is exclusively breastfed, it is just frequency of stool. Parents perceive it as diarrhea, but it's not diarrhea for you. Okay, very good. Now suppose it's a genuine diarrhea. Then if the onset is as early as 1 month, of course your feeding history is important. If it's a bottle fed baby, it could just be an infection because of poor hygiene. But what else will, so whatever starts soon in life, in general, what does it represent?
Sir, any congenital causes?
Very good. Excellent. So congenital cause. So these are rare. So when you say lactose intolerance, it could be any major enzyme deficiency, those chloride diarrheas, something which is very rare. But you think of congenital causes. So of course, you look at all the infection predisposition, bottle feeding, etc. And then you look at congenital causes. If the onset of diarrhea was around 6 months or at the time of weaning, then you think of infection, malnutrition, celiac disease, right? Now, suppose the onset of diarrhea, can you tell me any other age group where you will think of particular causes? Suppose it's an older child with chronic diarrhea, what will you think of?
Immunodeficiency.
Sorry, Amruta.
Immunodeficiency.
Immunodeficiency will be recurrent episodes. Yeah, Priyadarshi?
Intestinal infection.
Older child. See, when it is older child, you move away from infection. So you think of
Malabsorption.
irritable bowel
Inflammation.
syndrome, inflammatory bowel disease, such things. Okay.
जी.
And if it is after an acute episode, as we already said, it would be mismanagement or a complication or a vicious cycle because of which it is failing to resolve. Okay. And older child, we said, is irritable bowel and inflammatory bowel disease. Now, this question is extremely important. Was the child malnourished before the onset of the diarrhea? This is very important. So why is this important? What is this vicious cycle?
They are more prone for infections,
Okay.
and
Then because
malabsorption
of,
will happen. Malabsorption will
very good,
happen again. Vitamin deficiencies.
very good. Excellent. So malnutrition and diarrhea will lead to malabsorption. Malabsorption will lead to further malnutrition, and they are more prone to infection as well. And that will again get an episode of more diarrhea, and this vicious cycle will continue. Okay. Any other contributors to this vicious cycle? This is very important for practice point of view. So what do people generally do during diarrheas? How do they manage their children wrongly, parents?
Avoid giving food. They avoid giving food.
Antibiotics they will give.
Okay, so antibiotics may aggravate. Something else
Parents
before that
avoid
you were,
Hygiene, food hygiene.
sorry?
They will overfeed the child, thinking the child is losing.
Actually,
we will
no. Most
avoid
of the times they underfeed the child.
The
Okay?
starvation.
Most of the times they are underfeeding the children because they think that he cannot digest, so they starve him, and that leads to malnutrition, and that is very wrong. So we should, whenever parents ask us, should I feed my child during diarrhea? Your answer should always be yes. The baby or the infant or the child will decide how much to eat. The child will eat only as much as the child can digest. So there is no problem in feeding the child. What else will they do during diarrhea? Wrong. They may give wrong treatment. So they may, give some, like you said, antibiotic. So incorrect feeding practice, we already said, and other things like they may give some opium derivatives to stop the diarrhea, and in an infective diarrhea, it could lead to a lot of problems, right? So in history, we discussed about onset. Now we need to discuss duration and progress. So duration obviously is chronic. We already said that we'll ask whether it's recurrent acute episodes or it's a chronic continuous one. What about progress? What do you want to know in the progress? Yes, what do you want to know in progress? Utkarsh,
Frequency increasing
Sir,
or decreasing?
how is the general well-being? How is his appetite?
very good. So you
How is
want
his
to
weight
know
gain?
progress. Very good. So you want to know the progress of the general health of the child with respect to diarrhea. And you also want to know whether the diarrhea itself is getting worse, getting better, or recurrent, acute, as we said. So has it affected the growth of the child? This is extremely important. So therefore, you will always use growth chart while evaluating chronic diarrhea. Now, what are the patterns that you might see on the growth chart in a child with chronic diarrhea? Let's discuss only 3 patterns. So first pattern is weight normal, height normal. Child has chronic diarrhea. What does it mean to you? Rajakta, you want to speak? Weight normal, height normal, chronic diarrhea child. What does it mean to you? Come on.
No
Someone should.
malabsorption.
No malabsorption of nutrients. Yes. What else?
It may
Less
not
like
be chronic
increase,
diarrhea. It may not be chronic diarrhea, sir, when weight and height.
Yeah. So you'll have to get
substituting
into the details whether it's really chronic diarrhea or it's just increased frequency or what. So that is important. Then your second pattern is weight only affected, height is normal. What does this tell you? That this affection of weight or affection of growth is recent. So whatever is the cause of diarrhea, it has started affecting the child recently. And finally, your weight and height both affected, where weight is always more affected than height. This means it is long-standing issue, right? So this is about the onset, duration, and progress of the diarrhea. Now, how does the type of stool help you get some insight? Kalyani, you want to speak? How does the type of stool help you?
Sir, to differentiate between small
Sir,
intestine or
like if
large
there is
intestine,
perianal excoriation with
Okay, one sec. First, who was speaking, please continue.
to
sir, it's like
differentiate
if
between
in a
small
small
intestine and large intestine.
That's why I say
hello,
keep your video on. We can make out who's speaking and
hello,
you can raise a finger.
yes. Sir, like if there is a perianal excoriation with an explosive diarrhea, then it can be because of carbohydrate like there can be a lactose intolerance. There will be perianal
Very good.
excoriation with explosive diarrhea. That is one thing that we can ask.
Very good.
Then, if there is a bulky stool, which then we can like first of all we can have to distribute in like carbohydrate, malabsorption, protein. If different will have different manifestation in the stool.
Very
Like a
good.
lactose will have a perianal excoriation with explosive diarrhea. If there is any kind of a fat malabsorption, it will be bulky and sticky. And
Good. Protein malabsorption, the stool will be a little smelly, but basically there will be a lot of affection of growth in all these three, right? So that is about your carbohydrate, protein, and fat. What else will the type of stool tell you? So suppose it is absolutely watery or very watery. What does it tell you?
Secretory diarrhea.
Secretary.
Secretory or
large intestine.
Osmotic.
osmotic. It could be both. Even osmotic is watery. So now how will you differentiate between the two on history?
In secretory diarrhea, very large amount of a stool.
Very good.
It
Sir,
doesn't
after
resolve.
Osmotic usually subsides
after
after fasting.
after fasting, osmotic diarrhea will decrease.
Atul, one sec. AB18, 1 minute. Atul, what were you saying?
Sir, osmotic diarrhea usually subsides after fasting, keeping the child NPO for 6 hours under observation.
Very good.
Sir, if we
Very good.
stop food intake, the osmotic diarrhea will decrease.
Very good. So this is one important differentiation that you must ask. If the child doesn't eat, then does he still fast, right? Watery, both can be watery. You're right. So large watery persisting during fasting is secretory. The anatomy is small intestine. Large watery stops during fasting is osmotic because of non-absorbed nutrients. So now, if there, what are the reasons? Damage to mucosa during an infection can cause osmotic diarrhea. Decreased surface for absorption, as in celiac, can cause osmotic diarrhea. Reduced enzyme like a lactase deficiency post-viral, and increased load, that is your excess fruit juices. Okay. Now, besides this, what else? Suppose the diarrhea is not very watery, it's just loose, meaning there is a semi-loose or a consistency. What does it mean to you?
Motility disorder.
Very good. So it means that there is increased motility, and that is why the stool has not got enough time to get bound, and it has come as a semi-loose stool. So you have to find out reasons for increased motility. Okay. And finally, small frequent with mucus and blood is colonic mucosal invasion, that is infection. So these are some things that we must always ask in our history. What additional history you want to ask? This is about onset, duration, progress of diarrhea, about the type of stool. Now, what other history you want to know?
Family history of
Excellent. Then,
consanguinity.
So any milk
Regarding-
association, like whether it started after milk introduction, we can ask to rule out CMPA.
okay. So CMPA is a little complex topic, but yeah, we will talk about it. So can CMPA occur on breastfed babies?
Yes.
No,
Yes,
only
yes.
when cow milk is being
No,
introduced.
only
Rekha,
Cow-
you were
It
saying
can happen
something?
even- Yes, sir. It can happen even with breast milk.
Speak louder, Rekha.
It can happen even with breast milk.
Explain how.
Casein will be present even in breast milk, but it is in less quantity.
So basically, if the mother has consumed cow's milk or whatever foreign proteins, then also it has been described. So not means it's not limited to introduction of cow's milk to infants. But your question is okay, fine. So what are the other things that we quickly want? We want the birth weight. It is extremely important because we want to know malnutrition started when. Then every detail of feeding we want to know. We want to know even if it was breastfed, whether there was adequacy, whether the baby was happy with breastfeeding or kept crying. If it was top fed, the correct dilution of formula or whatever cow's milk was given, whether sugar was added or no. All those things we want to know. Then, of course, any history of food allergy, etc., in the family. Then, if in an older child you are looking at IBD, etc., then arthritis, eye complaints, etc. Then, North Indian origin community, maybe you will think of celiac, though, of course, we know it's common in many other communities. And then, of course, the treatment history. So, for all you know, some drugs are going on which are contributing to the diarrhea. So, these are all the important additional histories that you will definitely ask. Coming to examination, what will you focus on?
Anthropometry.
Excellent. So सबसे पहले growth chart. So you want to check all the anthropometry, decide on degree of malnutrition, if any. Besides this, what else would you focus on?
Signs of vitamin deficiencies.
Okay, so any signs of vitamin deficiencies. What else?
Signs of protein losing enteropathies, generalized edema, or
Okay,
swelling.
so any signs of protein malnutrition like edema. Very good. What else? So first, as usual, we look at growth and sickness. So growth you already said, then you look at whether it's a sick child or a dehydrated child. So chronic diarrhea usually will not be dehydrated, but if it is secretory diarrhea, sometimes it may be. So you have to look at the vitals. Then sickness will also suggest infection. So you have to look at whether it's a sick baby or a not sick baby. Then you already said deficiencies. Then you look at the skin where you will get other signs of deficiencies. You may get some eczemas, etc. in your rare disorders like A beta lipoproteinemia or whatever. Then your eye and your joints in older children, right? Now, our books will mention whatever 40, 50 causes of chronic diarrhea. What are the main causes? How should we group them in our mind? So you group them according to the age group. So we already said that in a early infancy, it would be congenital or surgical or things like that. Okay. Then a little later in infancy. So after say 2 months or whatever, that time, what are the causes that you will think of? Some you already told me. Quickly repeat. What can start at 2-3 months? Chronic diarrhea.
Around cow milk protein allergy, celiac, hyperthyroidism.
Okay, hyperthyroidism, yeah, but it's rare, so don't keep it so high. Celiac, why should it start at 3 months? Celiac, what is the classic age for starting?
After
So
weaning.
once complementary feeds are introduced.
Very good, which is usually 6 months. So don't put celiac first. So cow's milk, fine. What else? You said, na, if the baby stopped, then infection. So infection can come very early, 1 month, 2 months. So that is there. Then what else? Can cystic fibrosis come at 2-3 months with chronic diarrhea? Yes, it will come with respiratory complications also, but it will come with, it can come as diarrhea also. So depending on the age, there,
Immunodeficiency.
very good. Immunodeficiency, so that is HIV, then your post-gastroenteritis, then all kinds of infections, including parasite infections. Then after 6 months, you'll have celiac, food allergy, and all those things, right? And then in an older child, we already said Crohn's and IBS, or inflammatory bowel and IBS. Okay. How will you investigate a child of chronic diarrhea? Rekha, you want to answer?
So like we'll send the first basic investigation like CBC, LFT, KFT, serum electrolytes. Then we can go for some addiction testing like we can send a stool CS, stool RM to rule out any kind of infection. Then further if you are thinking of celiac, then TTG and IgA we can send. Like depending of the etiology that we are thinking, we can go for further workup.
Okay, good. So, try to be ready with justification of whatever investigation you say. So CBC, I will agree. Serum protein specifically is important. Full LFT, I don't know how and why it will help you, because if it's a liver disease, then basically the symptoms will be different. Then urine routine, of course, you will do. Then in stool, you said pH, yes. How does stool, what are the different aspects of stool routine that will help you? So when you're doing a stool routine in your mind, what two different categories are you trying to decide? Dharmendra, you want to
Absorption.
answer? Yeah, Pruthak, tell us.
Sir,
Pruthak?
we would like to look for malabsorption like fatty globules or reducing substances. And also we would like to look for any evidence of parasites. So ova for parasites.
Okay. So basically, you are trying to differentiate on one hand between a digestive absorptive problem versus an inflammatory problem. So digestive absorptive is all kinds of malabsorption. So transient malabsorption, long-standing malabsorption, carbohydrate, protein, fat, everything. So each one will have a different test. So like you said, pH and reducing substances will tell you carbohydrate. Stool, you can measure the fecal fat excretion. Inflammatory, you will look for by the presence of WBCs, blood, etc., and try and decide whether it's inflammatory. If it is inflammatory, next in you have to decide whether it's infective or non-infective. So that, of course, the history will tell you more than the stool routine report. Do you do a stool culture? Should you do a stool culture, Atul?
Yes, sir, if it's a persistent diarrhea, giardia can be visible in OISS also.
Yes. So giardia will be visible in your stool routine.
Yes.
Yeah. So what is the problem with a stool culture usually? When you do a stool culture, you will grow E. coli usually. And those E. coli, we don't have the facility to type them into pathogenic versus commensal. So that's why usually a stool culture is of no use. So if there is a chronic malnourishing diarrhea, then you may do a stool culture because you are looking for very unusual germs, very different kind of germs. Then you may get it sometimes in the stool. Okay, fine.
Sure.
Then TTG, IgA, you already said. Uh, Amruta, with TTG, IgA, what care that you have to take? What all else you have to do along with that?
Total IgA.
Very good. Total IgA, because if there's IgA deficiency, this test will come wrong. Then, depending on the need or what cause you are thinking of, you may think of endoscopy and biopsy. And only in surgical situations, you will look at barium studies, and food allergy tests again are of limited value. Now, let's come to management. How will you manage? So, what will be your approach in management?
First to look if any signs of dehydration are then there or not. So if there, then manage accordingly. After that, we'll look for the growth aspect of the child and the signs of malnutrition as well. So to supplement those elements, those micronutrients and vitamins as well. And then the definitive cause, as per the investigation or the history, the treatment for the definitive cause of the diarrhea.
So first is dehydration. Specific management depends on probable etiology, and you would like to start the child on food because mostly these children, you'll decide whether they are malnourished or not, and accordingly you want to start them on food. So what kind of food will you start them on? You start with lactose free or regular or what?
Regular food, sir. Only if lactose intolerance is suspected, only then lactose free. Otherwise, the regular food.
Very good. So you will start with regular food. Now, if you have to give a reduced lactose food or a lactose free food, how is it made? What is the source? Because otherwise all food is made of milk as your basic source of both carbohydrate and protein. So if you want to eliminate lactose, then what do you use as a basic source?
cereal.
Very good. So you use cereals in which you use puffed rice as a basic source of carbohydrate and some protein. And how do you add protein to that? You use egg white. Okay. So we said depends on etiology, growth unaffected or growth affected, then acuity of illness, OPD versus IPD, then dehydration, you already said, then nutritional rehabilitation, you said, and maybe drugs. So these are just the broad outline of management. So especially when you are writing an answer in theory exam on approach to chronic diarrhea, all these headings should come. Okay, that will give the examiner a very good impression that your management is quite um, detailed. Okay, and even when you are speaking in the exam on a practical case, you will choose these headings depending on which is applicable to your child. You will not talk in general, right? Okay. Now, in nutritional rehabilitation, we said early feeding. So, reduced lactose diet is based off you add puffed rice and don't use only milk, or you add cooked rice or suji. And lactose free is again you use cereals and egg white. Okay. Now, suppose you have a child means who cannot be managed even with a lactose free. Then what are the next progressive advanced steps in management? This will help in writing your theory answer. So how specific can you be in the diet? Can you give specific dietary substances?
Monosaccharide based diet.
Sorry?
Simple carbohydrate, monosaccharide based diet.
Very good. Excellent. So if this doesn't work, then you will go to a monosaccharide based diet. Suppose you have decided that there is a fat malabsorption or a protein malabsorption, then what can you do? Then you can give medium
The
chain
hydrolyzed
triglycerides, which
formula.
are, yeah, and protein hydrolyzed formula. So these are your formulae for fat and protein malabsorption. Okay. In an extremely severe case, you can do parenteral nutrition. And you already talked about micronutrient supplementation. And at times, you can talk of elimination diet when there is a specific food allergy, right? Okay. How will you judge the response to treatment?
Decrease in the frequency of stools, improvement in appetite and weight over progressive monitoring. So
Excellent. So response is reduction in diarrhea, whether the child is eating food and whether there is weight gain. And what is failure of response? Opposite. So increase in diarrhea, recurrence of dehydration, or failure to gain weight even 7 days after institution of treatment. Fine. What drugs can you use in chronic diarrhea? Come on, quickly.
enzyme supplements are like in pancreatic enzyme deficiencies. We can supplement enzymes.
Okay. Will you use any antibiotics in chronic diarrhea, thinking that there will be some chronic infection there? So usually chronic diarrheas will be non-infective unless it's a malnourished child with a superadded infection. So you will have to decide on infection based on presence of fever, sick child, and then your signs of inflammation in the stool, like your WBCs and RBCs or blood and all, and then decide. So only then will you use some antibiotic if necessary. Sometimes you may pick up amoeba or giardia and you may need to treat that. Here you have to be careful about something. So what finding in stool will you treat and what finding in stool will you not treat? For amoebiasis, anybody?
Like if we have got raised pustules in stool, like in RM, then we can treat.
What I wanted to say is that in amoebiasis, unless you get vegetative forms, you don't treat. It's not acute infection. If you pick up only cysts, then it may not be an acute infection and you don't have to treat. Treat from the diarrhea point of view, right? So that is about anti-infectives. What about Resica Dottrell? Would you give? Would you not give?
No, not recommended.
Yeah, so not recommended. In acute diarrhea also, it hardly shortens the duration of diarrhea. In chronic diarrhea, it is not likely to help unless it's a definite secretory diarrhea and you just want to try and reduce the volume, but otherwise no. What about probiotic?
Not much, no roles.
Yeah. So no definite proven role, so therefore you will not just randomly use probiotic. Okay. Now let's quickly take two cases and see what have you gathered. So 2-year-old boy presents with recurrent illnesses, diarrhea and respiratory infections. On examination, it's a malnourished child. Height is 78, weight is 8.9, and there's no other abnormality on systemic examination. So what will be your approach? What all you want to look at? What more do you want to ask in the history?
So we'll look for the for malnourishment. First, we'll look for the height age weightage, which in this case roughly corresponds to around 1.5 years. So both are almost equally affected, which suggests it is a chronic condition. Then, in case of respiratory infections, we would like to ask for the type of like frequency of the infections and hospitalization and severity of the infections.
Very good. What else?
And
Come on, others to add to what has already been said.
history of fever to rule out the current infective condition. History of fever.
Okay.
Type of diarrhea, it's watery or uh,
Very good. So you want details about the type of stool. Okay.
any perianal excoriations on,
Okay. Anything else? What will
any
you
family
examine
history or
further? You said perianal excoriation and all that.
signs of immunodeficiency, or any lymphadenopathy.
Okay. Fine. Now, the first thing that we said in diarrhea, what will we do is we will put a growth chart, right? So now this is the growth chart of this child. Okay. So these are your current height and weight reading. What can you make out from this? Come on, somebody to speak. What can you make out?
So
Rishika, you're not speaking today.
height and weight are both affected, but height is more affected than the height.
Very good. So height and weight both affected. Weight is more affected than height. So this confirms chronic malnutrition. So you can already make out that this has started a long time back. Okay. Now let's look at some previous readings and let's look at the growth chart. So now tell me, what is the onset of malnutrition in this child?
At around 1 year.
Okay. Any other
Onset must
guesses?
be around 6 months when I
Okay.
think the
So Utkarsh, why are you saying 6 months? He said 1 year. So why are you saying 6 months?
because the trend started falling.
Very
It
good.
was
So very good.
centiles down.
So you don't look at the point where the graph fell out of the normal range. You look at when it started falling. So it started falling around 6 months away. The onset is around that time. So what does that mean to you? Interpretation?
Around the time the child started weaning was started on weaning, right? When complementary food feeding was introduced.
So one reason could be that it is related to complementary food. So you will ask whether it started with complementary food and what food was started, etc. Now we also said one very important question is, how is the child before the onset of diarrhea? So in this case, how was the child in the first 6 months according to the growth chart?
Well growing, gaining weight.
Very well growing. So this is diarrhea that has started in a well-grown child. So if it has started in a well-grown child at 6 months, then one problem is that it is related to the complementary food that was given. What else could be the issue? It could have
Could
been
be an
faulty
infective.
weaning. Yeah, infective and faulty weaning. So therefore,
Improper weaning.
yeah, very good. So we said in our approach, most important is growth affected? So your growth is affected. Onset is at the time of weaning. So let's ask details whether there was any source of poor hygiene, bottle feeding, diluted milk, and this is the history that we get at that time. And it was a previously well-nourished child. And now finally you ask about what are the type of stool. So you get an answer that it is loose with mucus, often foul smelling, at times watery, explosive with perianal rash. So what is your interpretation of this?
Lactose intolerance.
Sorry?
Lactose intolerance could be a possibility.
Yeah, but is it only lactose intolerance?
So it can be fat.
Lactose intolerance.
Sorry?
Secondary lactose intolerance after.
Very good. And what is the primary problem?
Infection.
As there is mucus and
Excellent.
foul smell.
Yeah, so infection. So infection and secondary lactose intolerance. So what is your management?
Will give the antibiotic coverage to the child, and thereby the lactose intolerance will be for short time we can give low lactose diet, and then the normal diet can be continued and advice for the proper complementary feeds and proper feeding advice and nutrition.
Very good. So this is faulty weaning, infection, malnutrition, vicious cycle. So management is correct nutrition and hygiene. Antibiotic only if this episode currently is infective. Okay. Let's look at a second case. 2.5-year-old boy presents with recurrent respiratory infections and diarrhea since early infancy and poor growth. On examination, 78 and 8.9 kg, looks chronically unwell and pale. No other abnormality on systemic examination. What are your thoughts? It's since early infancy. So what should be your first question?
Previous
Sorry?
Type of stool.
A type of stool, yeah, but early infancy, first question should be feeding, no?
How early?
Whether it is
Previous
breastfeeding or bottle
complement.
feeding or top feeding, because that is going to make a very big difference. Okay, let's see the growth chart. So this is the growth chart here. These are the two readings today, weight and height. What does it tell you?
Both are severely
Both are
affected.
affected.
Very good. Both are affected and both are severely affected, as you said. So what does that severe affection tell you?
Sir, acute on chronic.
Acute on chronic malnutrition.
So yeah, it does say acute on chronic, but it also tells you two other things. What are they? When did it start?
Problem is from a long time.
Very good.
Child
Problem is
was
from a
never
very
normal
long time. We don't know whether child was
or
never
very
normal.
early deterioration of
Yeah, so that's the
growth.
right way. That's the right statement, that the problem has started very early in infancy. We already had a history that diarrhea started early in infancy. So the first interpretation is it started very early. And the second interpretation is because the weight and height is so badly affected, means what is happening due to the diarrhea, what is happening?
Malabsorption of nutrients.
Excellent. So the baby is not getting nutrients. So there could be a huge malabsorption or some issue, but the baby is not getting nutrients. Okay, so that's your second interpretation. Okay. Now this is the growth chart. What does it tell you?
6 months, around 6 months.
When did it
It has
start?
been below the normal range since around 2 months or
2
1 to
months.
2 months.
Very good. So it
2
started
months.
almost at 2 to 3 months. And when you ask the history, you are told that the baby was exclusively breastfed. So what does that tell you? What does it rule out? Exclusively breastfed and 2-month-old baby getting diarrhea and going down in weight tells you what? What is it not?
Not
Lactose
infected.
intolerance it is not.
Lactose
Sorry?
intolerance.
See, lactose intolerance is you are going to see commonly as a secondary manifestation only. So it's not going to affect the growth of the child. So what is this? Is it infection?
It is
No,
it is not
Unlikely to be infection.
If it is exclusively breastfed, unlikely to be infection, and yet baby is going down, so not getting nutrition in spite of taking in nutrition, which means some serious malabsorption. And then, of course, you ask for all other histories. There were respiratory complaints also. So your approach is growth affected, onset even while on good exclusive feeding, previously well nourished for the first 1 month or 2 months, and their large, bulky, foul-smelling stool. You said you'll ask the type of stool. So that tells you there is fat malabsorption and with serious respiratory infections. So this turned out to be cystic fibrosis. Okay. So what is the treatment? General supportive and whatever specific management you can give. Okay. So we'll stop here. Any questions?
Sir, in first case, the repeated respiratory infections was just because of malnutrition. Like that could be the only.
Yeah, that could be the only explanation, that it is because of malnutrition. Any
Sir,
other question?
I need to ask one thing. There is like some literature, like after acute diarrhea, there is some kind of a villus atrophy, which like becomes like chronic. like after acute diarrhea, there is some kind of a villus malfunction that becomes chronic when we are like continuously feeding the baby. So like is there any kind of a consensus like we should give low lactose diet, or sometimes people add lactase enzymes. There is Yamu drops people are giving lactase
Yeah.
enzyme. Is
So
it like literature?
I got your point. So my concept is like this, that after acute diarrhea, when there is villus atrophy, it is always temporary and it always heals in 48 to 72 hours. So there is no question of withholding food. In fact, you have to continue nutrition and the healing will happen on its own. Now this Yamu drops and lactase and all, I mean, it will give you the satisfaction of reducing that volume of diarrhea for those 1 or 2 days, if at all, maybe. But the point is that post-infection lactose intolerance is always transient. So unless the baby is nutritionally bad to begin with, it will always heal. Okay. So the consensus is that you give food, you don't withdraw food or you don't withhold food. Okay.
Thank you, sir.
Any other thoughts? Any other questions? Okay. So Aditi is in touch with you all and she will put up the next, I think already, I don't know if she's told you all, but Dr. Tushar Maniar will be taking off keys next week, I think. So she'll put that up. And whenever you feel that you all are ready for a physical classes, you please let us know, because that's going to improve physical examination technique, and it's much better than uh, whatever we can learn here. So let us know about that. Okay. Anything else? You all were asking about the recordings, so they will be put up shortly of the last 3-4 classes that were taken. Anything else?
Thank you, sir.
Okay, fine. Thank you. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.